have a question for you. Have you leaked urine when you run or jump, or worse yet, during intimacy? Do you go to the bathroom several times at night? Are you silently suffering from fecal incontinence? No one really likes to talk about this stuff, but it is real and a quality of life issue. My next guest is incredibly passionate about this topic, and the advances in urogynecology mean that we as women don't have to suffer the inconvenience and embarrassment any longer. Health, wellness, career, family, life, and the better side of 50. I'm your host, Michelle Folan, and this is Asking for a Friend. Hello, listeners. Today's guest is Dr. Michael Karram. He is a urogynecologist who is board certified in both obstetrics and gynecology and female pelvic medicine and reconstructive surgery. He's nationally and internationally known as a scholar, teacher, and a lecturer in advanced gynecologic surgery. He's authored and co-authored scientific papers that have been published in peer-reviewed journals. Welcome, Michael Karram.
Thank you very much for having me.
Dr. Karram, I was wondering if you could just tell our listeners a little bit more about yourself.
Sure. I'm married, have 2 children, both older. One's in San Francisco, one's in Seattle. I've been living in Cincinnati for the last 35 years. This is where I trained and began my practice, and I'm still in private practice here. My wife, Dania, is a certified financial planner, and we've had a very enjoyable and fruitful life. We're very happy to be here.
Well, great. Dania, your wife, was my first guest expert on the show. Also, in transparency, I used to call on you back when I was in sales. That's how I knew Dr. Karram. On top of that, my dad was a urologist. I know enough about this topic just to be super dangerous. It's great to have you here to lay all this out.
Thank you.
The premise of the show is I give listeners a heads up about who I'm going to be interviewing. I got a lot of engagement from the listeners around this topic because I think this really resonated with the people that listen to this podcast. One of the first questions I received from one of our listeners was, what does a urogynecologist specifically treat?
That's a good question. And let me start by maybe explaining the whole specialty of obstetrics and gynecology and urogynecology, because they are intertwined together. Obstetrics and gynecology is obvious. It takes care of babies and delivering babies, as well as female problems in the gynecology world. Basically, 2013, there was a new subspecialty within the field of obstetrics and gynecology called urogynecology, or what is more scientifically called female pelvic medicine and reconstructive surgery. And that is what urogynecology is. And urogynecology basically deals with problems or conditions involving abnormalities in the pelvic floor, in the female, obviously, and the organs related to the pelvic floor, which would be the uterus, the vagina, the bladder, the rectum, and the pelvic floor muscles. To become a urogynecologist, you have to be 4 years of training in obstetrics and gynecology, and then 3 more years of training in urogynecology or female pelvic medicine and reconstructive surgery. And what's interesting about this field is that you can train both from the OBGYN tract or from the urology tract. So there are urologists who train in urology and then also train in urogynecology. So urogynecology is not just totally obstetrics and gynecology physicians, but is also urology physicians as well throughout the country and throughout the world.
Okay, got it. So the pelvic floor issues then cover a plethora of things that you're going to see. So when someone comes to see you typically, what are they most often concerned with? What are their issues?
I would say the most common conditions that we see are related to urinary incontinence, and there are all different types of urinary incontinence, fecal incontinence, all types of different fecal incontinence issues, and then pelvic organ prolapse problems related to the organs in the pelvic floor, which would be a prolapse of the bladder, a prolapse of the rectum, a prolapse of the uterus, a combination of all three associated with urinary incontinence, fecal incontinence, all of the above, etc. So it really relates to all of those organs and the problems related to the organs. It also relates to the pelvic floor musculature. Certain women under certain conditions have times where they will have pelvic floor contractions, which will cause them to have a lot of pain. It will cause them to have problems with intimacy with their partner because they have what we call spasms of the levator muscles, which are the main muscular component of the pelvic floor. And so we deal with those issues as well. And that brings into our arena pelvic floor physical therapy and medications related to the pelvic floor and the musculature of the pelvic floor.
Okay. There's two different types of urinary incontinence. I think there's stress incontinence and urge incontinence.
That's correct.
Can you define the two?
Sure. But there's more than just those two. Those are the most common. They probably entail 85 to 90% of the types of incontinence that we see. But there are other types of incontinence related to abnormalities in the bladder, like a neurogenic bladder, things like this, but very rare to see. And those are more complicated situations. But yes, the most common urinary incontinence that we see is stress incontinence, and that's defined as involuntary leakage of urine. In other words, you leak urine when you don't expect to leak. And there is some provoking factor. Usually it's cough, sneeze, laugh, jump, exercise, intimacy. Something will promote the leakage. It doesn't just spontaneously leak. And that's called stress incontinence. Stress relates to there is some provoking factor. Then urge incontinence is what most people would remember or think of as gotta go, gotta go, gotta go. It's feel the urge to go, and you can't get to the bathroom quick enough, so you leak on the way. Or sometimes you'll just spontaneously leak. You'll feel the urge to go and all of a sudden leak on yourself. And that's called urgency or urge incontinence. And the difference between the two is, in a broad sense, stress incontinence is usually treated with some type of a surgical procedure or something related to surgery. Urge incontinence is treated more with medical drugs and medicine and some other types of non-surgical therapies. But those would probably entail 85 to 90% of the incontinence that we see when it comes to urinary incontinence.
So how often are you able to send someone to, say, a pelvic floor therapist to give them some help in this area?
Actually, quite frequently. It usually relates to how bad the symptoms are and how they're affecting the quality of life of the patient. So a lot of times women will come in and it'll be very mild. It'll only be under certain circumstances. It bothers them, but it's not life-altering or affecting their quality of life. We tend to be more conservative with them and say, okay, let's start with pelvic floor physical therapy. Let's see a therapist and she'll work on you and see what happens. And a lot of times they'll get results that they'll say, you know what? It's fine. It's helped me. It hasn't maybe cured me, but at least I can function like this and I can do the things that I want to do. And we say, hi, that's great. And that's the end of it. On the other hand, if somebody comes in and anatomically by exam, we can see that there's a lot of anatomical abnormalities. There's a lot of laxity and weakness in the certain areas that support structures. I can't say that pelvic floor therapy wouldn't help, but I would say the chances of it helping are very, very low. And these are women that come in and they've exhausted all sorts of Kegel exercises and over-the-counter medications and all this other stuff, and they're like so frustrated they can't function. Those are the ones that we say, okay, usually we'll just go to surgical procedures or medications that would be required under those circumstances.
So my dad used to always say, do your Kegels, do your
Yeah.
Kegels. But I guess at some point, Kegels can only do so much and pelvic floor therapy can only do so much. I will say, I had quite a few women write in questions saying, after I had my last child, I don't know what it is about that last child. It was like, that's when all the problems started, and it keeps getting worse. Last children can be problems for other reasons too, but
yeah, right.
but at least for this, it just seems like that is a common theme here.
Right. Giving birth is probably the most common predisposing factor to pelvic floor abnormalities. And it only makes sense when you have a baby and it's delivered vaginally. You do get a lot of pressure and denervation and devascularization, which means the nerve supply and the blood supply to the muscles of the pelvic and the blood supplies that go to the organs. And over time, with the stretching and the weakening, they do weaken. And that is why that's the most common predisposing condition. Now, people would say, well, that means then if I had C-sections, I won't suffer from these problems. And what's interesting is that's not true. There are many women who we see who have had no vaginal births and have had all C-sections, but still have significant pelvic floor abnormalities, urinary incontinence, or pelvic organ prolapse. So there is a genetic component to this. We've even seen women that have never been pregnant before have significant problems. So it's not just the predisposing factors, which are the most common, but there is a genetic component that for some reason, women and men under certain circumstances, hernias, for example, will have these types of abnormalities, even though they've never had a predisposing factor, because they are born with tissue that it either is weaker or cannot tolerate certain types of stress and gets weaker over time.
Ugh.
Yeah.
God. It's not necessarily gravity or aging. It's some of just genetic predisposition.
Absolutely.
That's interesting.
There are other women who have had 5 vaginal deliveries, all large babies, 8, 9, 10 pounders, and they come in and they have absolutely no issues whatsoever. No prolapse, no incontinence, no nothing. They are perfectly fine and everything is well supported. So it's multifactorial. Everybody's different. I might throw this into the discussion right now is that's why it's very important when people have these issues that they see a specialist or a physician that deals with these things before they start talking to all their friends, because everybody's different. What happened to your friend, she might have had the exact same symptoms, but a totally different anatomical abnormality that would cause her maybe not to respond to certain things, and you will respond to certain things. So that's the first thing I tell people is don't talk to your friends because everybody's different. I mean, talk to them, but understand that you are different than her. It's like comparing apples to oranges.
Right. I want to get back to the bowel incontinence question, because
yes.
I do have a listener that said that when her child was born, the child was born face up rather than face down, which put, I guess, some extraordinary pressure on her bowel.
Right.
And to this day, I think she's still kind of having issues. What do you typically do in those cases for a patient like that?
Well, again, it depends on the reason. I would say theorizing under those circumstances, when a baby's in a malposition for delivery, the larger part of the diameter of the head is coming through, so everything gets stretched more than it would normally if it's in the face down position, because that's the smallest diameter of the head coming through the pelvis. But under certain circumstances like that, it's not just pressure on the rectum and the pelvic floor, but there's something called the sphincter of the rectum, and that is a muscle around the external opening of the rectum that actually closes down and gives you the voluntary ability to stop losing stool or anything like that, as we've all experienced. Under certain circumstances related to birth, if they tear that sphincter, and there's an internal sphincter and an external sphincter, if that sphincter tears, then that musculature is totally gone. And that is one of the common types of fecal incontinence related to delivery, where we have to go in and repair the sphincter. The other issues that can happen are because of the large diameter of the head coming through gets stretched so much that the nerves get stretched and the blood vessels actually tear. So again, if an organ or a part of the body needs to work correctly, it needs a normal blood flow to it and a normal nerve supply. If the nerves are stretched, it's not going to work, and that connection is not going to be there as good, and so it won't work as well. But theorizing, that's probably maybe one of the reasons why this patient has a problem. She might have a sphincter tear.
Got it.
Yeah.
How often do women come in? Maybe it's not so much incontinence, but pain during intercourse because of pelvic floor issues.
Yeah. That again is a condition that we see, and it may not be pelvic organ prolapse or related to urinary incontinence. It might just be related to menopausal issues, hormonal issues, or vulvar issues. Okay. Menopausal issues, probably the most common would be what we call menopausal vaginal atrophy, where the lining of the vagina gets very thin. And so it doesn't produce the lubrication that it normally does in the premenopausal state. And so because of that, the vagina doesn't stretch, it tears, it doesn't lubricate. So intercourse is uncomfortable, and sometimes they bleed, and it's very disheartening to them because of that. That's an easy fix, either medically, sometimes surgically, depending on the situation. But most of the time it's treated with medicine. And then there are vulvar conditions, which is the outside around the opening, what we call the introitus. One condition is called vulvodynia, which is a condition on the outside, right between the rectum and the vagina, where, again, you get a very, very thin area that's, whenever it's traumatized or rubbed against, is very painful.
Okay.
So those are conditions that are usually related to non-surgical or non-pelvic organ prolapse. But then again, if a woman has pelvic organ prolapse, and if I would say the most severe case would be the uterus is hanging outside the introitus, outside the opening, the bladder is hanging outside, and the rectum, they are not going to not only be uncomfortable having intercourse, they can't have intercourse. And a lot of times, if it's maybe not that bad, but it's still there, husbands or partners are very reluctant to have intimacy because they're afraid they're going to hurt their partner and they don't want to hurt them. So that can come into play as well if you have prolapse or urinary incontinence. And then the incontinence, there are women that leak when they have intimacy, and that just really shuts everything down because, there's nothing worse to a man or a woman when they're having intimacy and somebody leaks on themselves. It's very, very disheartening.
Right. Yeah. And it's very real.
Very real. Very real.
Could a partner technically feel if you have some organ prolapse? Would they be able to feel that?
Oh, absolutely. Absolutely.
Okay.
The normal vaginal length is about 9 to 10 centimeters. And normally the bladder sits above the vagina and the rectum below. There's no bulging of either one. If all of a sudden something's bulging, or the uterus is dropping and the cervix is right there, then all of a sudden they're sitting at like 2 or 3 centimeters going inside the introitus. They're going to hit it. Mm-hmm. And if you hit the cervix or you hit the bladder or you hit the rectum, if it's bulging in the vagina, it's going to be very uncomfortable to the female. And the husband's going to say, whoa, what am I hitting here? Am I hurting you?
Right.
And that can also cause incontinence, either rectal or urinary, because they're pushing on the bladder, pushing on the rectum.
Ugh.
So yeah, they can definitely feel it. Definitely feel it.
Ugh.
And then in certain circumstances, they can even see it.
Okay.
Yeah.
All right. Last time I was at the GYN, which now I think about it, I probably need to make an appointment.
Yeah.
There was a sign advertising for vaginal rejuvenation.
Okay.
And you and I didn't talk about this in our first call, but I was curious about that. If you can give us any kind of insight into what vaginal rejuvenation is and why people go that route.
Yeah. It's a term that's used mainly to describe a procedure, and everybody does the procedure or procedures differently to basically make things tighter down there.
Okay.
It was more of a marketing term than anything else. We've been doing vaginal rejuvenation for eons and eons of years just by doing surgery for pelvic organ prolapse. But as time has evolved, there are certain conditions now or patients who say, you know what, I've had one child and I don't have a lot of prolapse, but it still feels loose to me. It feels loose to my partner, and I'd like it tightened. Okay. That's basically what vaginal rejuvenation is. Now, how do you do that? There's a multitude of different ways, and there's a lot of discrepancy between one person as the other as to what the best way to treat it is. However, now you introduce medical device companies, laser companies, and other companies that now have these devices that are very expensive that say, by using my device, and it's a radio frequency device, you can tighten everything up and quote unquote get vaginal rejuvenation. So it's a marketing tool for a lot of these lasers. But the bottom line is basically vaginal rejuvenation is anything that you do, whether it's surgical or non-surgical or laser or any other instrumentation, that will tighten up the vaginal lining and the vaginal introitus and the area around or inside the vagina to make it tighter, most commonly related to loosening from childbirth. But that's what vaginal rejuvenation is, basically tightening everything up.
I'm really glad I asked. Thank you.
You're welcome.
All right. One of my listeners, she was like, I need help with this, so please ask him.
Okay.
She said that she was sent to a urologist to get properly diagnosed with her urinary incontinence. And they were telling her it required catheterization. They've tried twice. She just can't do it. And she was wondering if there's another way to diagnose her issue without having to be catheterized.
Okay. I think I know what she's referring to, and it's urodynamics. That is a test that we use under certain circumstances. You don't always have to use it, but urodynamics is a test where we can measure the pressure in the vagina, the pressure in the bladder, the pressure in the rectum, and the pelvic floor pressure during certain times, like when a patient coughs or valsalvas or strains or something like that. All that information is important to us to decide whether we're going to treat them surgically or medically or both, and what type of surgery to use. So under certain circumstances, it's probably, I guess the answer would be most likely no. If you have a certain condition where we need that information to give you the best treatment, you need to have it done. If, on the other hand, does every woman who has incontinence or something related to incontinence need urodynamics? It's absolutely not. So I'll give you a prime example. When a woman comes to me and she says, you know what, doctor, I'm leaking when I cough, sneeze, strain, I have stress incontinence. There are three things that I have to prove before I can start treating her without any other treatment. Number one, she has to demonstrate stress incontinence to me. So I fill her bladder up and I have her cough and sneeze or do whatever action she needs to do. If she shows me that she's leaking, then that's a diagnosis of stress incontinence. Then I have to, number two, rule out that she has emptied her bladder completely. So I do what we call a post-void residual. Because if a woman doesn't empty her bladder completely, then she's always going to leak because her bladder is always full. And there's a lot of reasons why they don't empty their bladder completely. But let's get back to the patient. So she showed me she leaks. I do a post-void residual. She emptied her bladder completely, and she doesn't have an infection. because some women who have bladder infections or what we call cystitis will have leakage. And all you have to do is treat the infection and they're gone. Once they've had those three things and they have no other issues, they are a candidate to be treated for stress incontinence. Now, where the urodynamic comes in is a woman will say, I not only leak, and I demonstrated that, but I'm also having the urge. I leak spontaneously. I'll be sitting there and I won't have to go and I'll hear the water running and I leak. I get up 3 or 4 times a night. Then we have to say, okay, as a clinician, I have to say, is that really stress? Is it urge? Is the urge worse than the stress? If I treat the urge, will the stress get better? That's where all this information that we get from the urodynamics helps. Without that information, we'll be just spitballing we can't really determine scientifically what the best treatment for her would be.
Got it.
So that would be urodynamics, but by no means does it have to be everybody.
All right.
Second reason would be, for example, if somebody's had a previous surgery or a previous incontinence procedure and they come back and they have a repeat, now we have recurrent incontinence, they always have to be worked up with that because you can find things that clinically won't show up that these pressure volumes and things like that will tell you.
Got it. Okay.
And quite honestly, I've sent tons of patients to urodynamics, and it sounds more threatening than it really is. Most of them come out saying, oh, that really wasn't that bad after all. It's not a comfortable procedure, but it's not as discomforting as people think it's going to be.
All right. I will let her know because I'm not going to make her wait.
Good.
And then the other thing, because I think a lot of women may be hesitant to address their issues because they think of mesh bladder slings and the lawsuit commercials. I even had one listener say that, oh, my mom had that done years ago and she's still having problems.
Okay.
How are you currently fixing those issues, and have they improved that procedure with that mesh sling?
Right.
I told you, I know just enough to be dangerous.
No, that's okay. That's okay. I think, again, this gets back to talking to other people and what they've had done, because what they've had done and what you need might not be the same or might be different. But that's a very good question. First of all, if you talk about stress incontinence, because that is what we use a sling for, it's really not a bladder sling. It's a urethral sling. Women who have stress incontinence and only stress incontinence with no other problems, no pelvic prolapse or bladder prolapse, their problem is related to the urethra, which is the tube that you pee from, not the bladder. So when I do a sling, it's a suburethral sling. It sits under the urethra. So I don't even touch her bladder. Okay. I put it under the urethra because that's where the weakness is, in the urethra. There is no such thing as a bladder sling, in all honesty. Now, there were some mesh products that were used and have been taken off the market to repair bladder prolapse, okay? What we call a cystocele or a rectocele. That's putting a piece of mesh between the vagina and the bladder to hold it up, and between the rectum and the vagina to hold it in place. Okay, those procedures have been taken off the market. That is totally different than a sling for incontinence. They are mesh, but they're totally different. Size of mesh, type of mesh, everything is different. And I can tell you, the way we used to treat stress incontinence 20 years ago and how we treat it now is like night and day. That used to be a 3-day hospitalization with a big incision across the lower part of your abdomen and a 6-week recovery. Stress incontinence slings, suburethral slings, are 15 to 20 minute outpatient procedure back to normal activity within 7 to 10 days. And they work better than the old procedures that we used to do.
Wow.
So it's revolutionized how we take care of women for stress incontinence. I mean, it's like night and day. And I can tell you scientifically, there is more peer-reviewed evidence based on multitudes and multitudes of studies all over the world showing how safe a sling is for stress incontinence. So that would be, you hear things like, what is the standard of care? That would be the gold standard of care for the treatment of pure stress incontinence in the right patient anywhere in the world. You go to a board certified urogynecologist with that condition, they're all going to tell you that a sling is the gold standard. Now, have other things come into the market? Absolutely. But the data associated with those types of treatment don't even remotely get close to the data that supports the safety and efficacy of suburethral slings for stress urinary incontinence.
That's good to know. You hit on what the recovery and what patients should expect, but do you send them home with just something for pain?
Yeah, usually if everything went well, which most of the time it does, and we're just doing a sling, they go home on maybe a day or two of pain medicine like Vicodin or Percocet, and then they switch over to regular strength Tylenol or Motrin or ibuprofen products, and that's it. Yeah, very, very quick and very effective. Very effective.
This is one of those topics that I speak of because if you're 55 years old and you're having stress incontinence, you could be dealing with this for the next 30, 40 years. This is really a quality of life issue, right?
It really is. Almost all the things that we deal with are quality of life issues. Stress incontinence isn't cancer. It's not going to kill you. Fecal incontinence isn't cancer. It's not going to kill you. If your organs are falling out, it's not going to kill you like cancer or something like that. But, can you enjoy your life? And 50 is good. There are a lot of women in their early 40s who have incontinence. All of a sudden, they can't play tennis. They can't run. They can't jog. They can't get on the trampoline with their kids. They can't do any of that. And that is a quality of life issue. That's where their lives are right now, with their kids and having fun and doing things with their husbands and exercising and that. If they can't participate in that, forget 60, 70, or 80. This is in their 40s and 50s.
Right.
And it's such an easy treatment and so effective that when people come in, when they're done, it's just like, I always used to get, oh, you delivered my baby and you did this. And, when a woman had bleeding issues and we would do something called an ablation and we'd stop her bleeding, this. Now it's like, oh my God, stop somebody from leaking and they think you are God.
Well, yeah. Again, it's the self-confidence, it's the embarrassment, the oops. We've all had it. My dad used to call it garage door urgency. You're fine until you pull in the driveway and then you're sitting in a car waiting for the garage door to go up. And then all of a sudden it's like, oh God, I got to go to the bathroom. So anyway, you're extremely passionate about this. And I can tell, and I love that about you, that this is, this is something that you really want to help women. And I think getting this out there and that people understand that there are options and really effective therapies and surgeries that can help them. I'm so glad we talked about this today. If you were going to share some advice with our daughters or younger women about their pelvic floor health, what would you tell them, like a 30 or 40-year-old woman?
Just like anything else, it's important to maintain a good lifestyle. And that involves a good diet, healthy exercise program. Don't do anything that involves a lot of real heavy lifting, a lot of lifting that will put pressure on your pelvic floor if you don't have to. Learning how to lift things appropriately, not only for your pelvic floor, but for your back and for your other parts of your body that we normally weren't really educated in. There's now so much information out there as to how to exercise appropriately, how not to put strain on your back, how not to put strain on your neck, et cetera, et cetera. Same thing goes with the pelvic floor. Mm-hmm. Now, some women have manual labor jobs where they have to do that. But then again, there are certain things that maybe they can introduce into their work style that will help them. But it's basically just lead a good, clean, healthy life from a dietary standpoint, exercise standpoint, maintaining your weight. That's very important. weight is probably one of the more common causes of urge incontinence. There's a really nice study that shows women who are obese are 2 to 3 times their normal BMI have an increase of urge incontinence by 50%. And if you lose 8% of your BMI, you decrease your episodes of incontinence by almost 80%. So if somebody comes in to me and we diagnose them with urge incontinence, and we've also diagnosed them with obesity, whatever diagnostic tool you're going to use, first thing I say is lose weight and it'll help. Now, unfortunately, that's not as easy as it sounds. I can't just send somebody out and say, oh, go lose 50 pounds and come back and I'll bet your incontinence is better. Because quite honestly, most people are very conscientious of their weight and they're trying to lose weight. And by coming in, they're saying, you know what? I'm not losing weight, or I'm not losing weight at the speed that I want to lose. Are there other things that you can do for me? But a combination of the two works very, very well. It's basically good health, good diet, good exercise programs. And when it comes to the pelvic floor, doing Kegels in preparation for childbirth, doing Kegels after childbirth, those types of things, always good, always good.
Mm-hmm.
Especially when you're younger, because the pelvic floor muscles are just like any other muscle. Unfortunately, you can't pump iron with your pelvic floor, but there are a lot of things that you can do to strengthen the muscles. And actually, with all the physical therapists that we have now that specialize only in pelvic floor therapy, they really do a fabulous job at helping women maintain the strength in their pelvic floor. And it's more preventative than after the damage has been done, whatever caused the damage, then let's do the pelvic floor. You won't get the same results as if you do it preventatively.
Got it.
You know, I would say our understanding of these abnormalities and these pelvic floor abnormalities is changing so quickly. In response to people say, I don't like to talk about it, or I talked to my friends about it and they had something done and it didn't work. Don't take that as there's nothing out there, because there are new treatments that are coming up all the time. I mean, we've got new treatments now for stress incontinence. It's called periurethral bulking agents, which are very, very easy to do. We've got treatments for overactive bladder now, where we use Botox in the bladder. Oh my gosh, I've got so many patients that have tried multiple medications and neural stimulation and things like that, and it didn't work. And a 10-minute Botox procedure in their bladder, and they walk out and they're feeling like this is amazing. So the science is transforming so rapidly that things come out every 6 months or something new. You don't want to hide your symptoms, but you want to bring your symptoms to the forefront. Talk to your doctors about them. If you don't get answers, find other doctors. There are plenty of specialists in every city in the country. There is help for you. Take the bull by the horn, so to speak, and find somebody that can help you, because there are plenty of people out there. That would be some advice that I would give everybody. Don't suffer in silence, because you don't have to anymore. This isn't something that you have to live with, or something that naturally comes with aging, or something that because your mothers or your grandmothers had it and they couldn't get treatment 50 years ago, that you're in the same boat. It's not the case anymore. Absolutely not the case.
This has been great advice. Thank you so much for really giving us the soup to nuts on this. You're going to help so many women. We don't talk about this stuff, just the information doesn't get out there. And women, as much as we do talk to our friends, sometimes we don't get in the weeds about some of these things because it can be embarrassing. So thank you so much for giving us some clarity today. And thanks for taking the time out of your busy day to be here.
You're welcome. I appreciate it.
Thank you so much.
You're welcome.
Appreciate
Take care.
Please refer to the show notes for this episode for Dr. Michael Karram's contact information. He is happy to field your questions and provide referrals to qualified urogynecologists in your area. Follow Asking for a Friend on social media outlets and provide a review and share this show wherever you get your podcasts. Reviews and sharing help us grow.